Very warm morning to one and all present over here. We group 46 to 60 are here to discuss the seminar on the pelvis. Now, let us look first at a clinical case. A 38-year-old multiparous woman present with the feeling of pelvic heaviness and something coming down in the vagina, especially at the end of the day or after lifting her toddler. The history revealed that she had two forthcoming vaginal deliveries. Also, the symptoms show she had mild backache, heaviness in the pelvis, no urinary or bowel complaints. Her speculum exam revealed that cervix is seen just inside the vaginal opening during straining. Now, to diagnose this case, we need to study the uterus in detail. So, here I am, Master Zadav Omkar, roll number 50, starting with the basics of the uterus. When we look at the uterus, it is a thick muscular organ located in the pelvis. Towards its anterior side lies the urinary bladder, and towards the posterior lies the rectum. While looking at the cavity of the uterine cavity on the coronal section, it appeared to be triangular with apex pointing downward, and while in the sagittal section, it appeared to be a vertical slit. As we can see in the diagram, it appears as a vertical slit here and as a triangular cavity in the coronal section. Moving forward, let us take the parts of the uterus. While taking the parts, we see that there are multiple parts, beginning with the uppermost part, which is fundus, the middle part, which is body, and the lower and narrow part, which is cervix. Other parts are the chrono and other borders are anterior and posterior, which consisting two lateral borders. When we describe them in detail, we can see that the fundus, which is the uppermost part, is a dome-shaped structure which lies just above the fallopian tube opening. It is seen that at the posterior wall of the fundus, we see the implantation when the fertilized oocyte implants at the surface. Along with the posterior upper part of the body is a common site for its implantation. Next, we see the lateral borders. Lateral borders are the two side borders. Generally seen, they are rounded, concave, and generally known for their attachment to the broad ligament. While considering the cervix, it is a lower cylindrical part which acts as a passage for the fetus during parturition. While the cervix communicates with the uterine cavity with internal OS and with the vaginal cavity with external OS. As we can see in the diagram, here it communicates with internal OS and where it communicates with vagina with external OS. Also, the junction os. While the junction between the body and the cervix is also called as isthmus. While looking at towards the dimension of the uterus, we see that the uterus is 7.5 centimeter long, 5 centimeter broad, and 2.5 centimeter in thickness, while weighing around 30 to 40 grams. Considering the layers of the uterus, there are three main layers. The innermost is the endometrium, myometrium middle, and perimetrium is towards the outer side. Considering this layer, we see that the perimetrium is the outermost layer, which is thin, consisting of the simple columnar layers. Well, to describe it in more detail, here we can see the histological slides. In this consists of the endometrium, myometrium, and the thin layer we see is the perimetrium. More high-power diagram shows that there are two layers, stratum functionalis and basalis. Generally, the functionalis is the layer which is considered to shade out during the menstrual cycle, which consists of mainly the thick blood vessels and the glands, while the basalis tends to remain constant during menstrual cycle, while the muscular layer consists of the smooth muscle fibers. Now, let us look towards the axis of uterus, so I'd like to call Shivam for explaining.
Good morning everyone, myself Shubham Jogdan, roll number 52. I am going to discuss about axis of uterus and its Let's start with the axis of the uterus. The position of the uterus in the pelvis is described using two main angles formed by the axis of the uterus, cervix and vagina. Firstly, the angle of antiversion. The angle formed between the long axis of the cervix of uterus and the long axis of the vagina is called the angle of antiversion, and it is about 90 degrees open forward. position. This means the cervix is tilted forward relative to the vagina. Significance of the angle of anteversion. This forward angulation keeps the uterus in a stable position over the urinary bladder and supports normal uterine function. Alignment with vaginal axis may cause bulky uterus to descend through vagina leading to prolapse. This is the long axis of the cervix and this is the long axis of the vagina, and this angle between these two axes is called angle of anteversion. Maintenance of the angle of anteversion. Angle of anteversion is mainly maintained by the two ligaments. This is the round ligament of uterus. Traction of this ligament causes forward pull on the uterine fundus. Secondly, uterosacral ligaments. Traction of this ligament causes backward pull on the cervix. Angle of antiflexion. The angle formed between the long axis of the cervix and the long axis of the uterus is called angle of antiflexion, and it is about 125 degree open forward. Position. This indicates that the body of the uterus is bent forward over the cervix. This is the long axis of the cervix and this is the long axis of the body of the uterus, and this angle between these two axes is called the angle of antiflexion. Significance of it. This configuration helps in maintaining the uterine cavity in its normal anatomical relationship. It allows proper drainage of menstrual blood and is optimal for implantation. Clinical importance. A uterus that is retroverted, that means angle of anteversion reversed, or retroflexed, that means angle of antiflexion reversed, may lead to dysmenorrhea, painful menstruation, dyspareunia, that means pain during intercourse, or infertility. Uterine position and rotation. Normal position of uterus. The uterus is usually lies in the median plane. It is twisted along its long axis, either slightly to the right or left. Dextrorotation of the fundus. The fundus may tilt more to the right pelvic wall due to the pressure of the sigmoid colon, and this condition is called the dextrorotation of the fundus. Levo-rotation of the cervix. As a result of dextrorotation, the cervix tilts more toward the left side, toward the left ureter. This condition is called levo-rotation of the cervix. Now further topic my friend Om will take.
So, good morning everyone. Myself Om Ipar, roll number 49. As of now, we have seen various parts of the uterus, and now I will be talking more about the cervix. Firstly, cervix is the lower cylindrical part of the uterus. It is less mobile than the body. It is about 2.5 cm long and is slightly wider in the middle than that of the either end. At birth, the cervix is twice in length than that of the body, and after puberty, the body of the uterus elongates and it becomes more longer than the cervix. Hence, the ratio of cervix to body at birth is 2:1, which reciprocates after puberty and becomes 1:2. Further, the lower part of the cervix projects into the anterior wall of the vagina, dividing it into two parts, the supravaginal part of the cervix and the vaginal part of the cervix. As it can be seen in the diagram, it shows the supravaginal portion and the intravaginal portion, which is vaginal part of the cervix. Now let's speak about the topic fornices of vagina in brief. The interior of the upper end of the vagina is in the form of a circular groove that surrounds the protruding cervix. The groove becomes progressively deeper and divide into four parts called as vaginal fornices. Firstly, there is the anterior fornix, which lies in front of the cervix and is the shallowest. Secondly, there is a posterior fornix, which lies behind the cervix and is deepest. Lateral fornices lies one on each side of the cervix. The study of these topics helps in understanding the relations of the cervix easily. As in the diagram, we can see there is the anterior fornix in front of the cervix. There is posterior fornix behind the cervix, and lateral fornices cannot be seen in this section, which are present each on either side. Nextly, let us talk about the relations of the cervix. The anterior relations of the cervix. Firstly, supravaginal part of the cervix is related to the posterior surface of the urinary bladder, and vaginal surface of cervix is related to the anterior fornix of the vagina. As can be seen in the diagram, the urinary bladder, the posterior surface of the urinary bladder is related anteriorly to the cervix, and as we have seen in the previous slide, the anterior fornix is also present anteriorly to the cervix. Talking about the posterior relations, the supravaginal part of the cervix is related to the rectouterine pouch with the ileum and sigmoid colon coils in it. And secondly, the posterior part of the cervix is related to the posterior fornix of the vagina. In the diagram, we can also see the rectouterine pouch which lies posterior to the cervix. Nextly, talking about the lateral relations, the supravaginal part of the cervix is related to the ureter and uterine vessels, and the two lateral fornices lies on each side of the cervix, which is seen previously. And here you can see these are the ureters and these are the uterine arteries, which are the lateral relations. Nextly, let us talk about the cervical canal. The cavity of the cervical canal is fusiform in shape. It communicates above with the cavity of the body through the internal os and below with the cavity through the external os. The canal is flattened from before backwards, so has anterior and posterior walls. These walls shows mucosal folds which resembles the branches of a tree called the arbor vitae utera. As in the diagram, you can see there is upwards you can see the internal os, below we can see the external os, and in between the mucosal folds resembles in a pattern showing resembles a tree. So the folds in the anterior and posterior wall interlock with each other and close the canal. In a nulliparous woman, that is a woman who has not born any child, the external os is small and circular as can be visualized in this diagram. And in a multiparous woman, that is a woman has given birth to either at least one child, the external os is bounded by anterior and posterior lips, both of which are in contact with the posterior wall of the vagina. It gives a slit-like appearance as it can be seen in the this figure. Now I would like to hand over the mic to Karthik to talk about his topic changes in the uterus with age.
Good morning everyone, my name is Karthik Patel, roll number 58. Up till now we have talked about shape and the location and parts of the uterus. The uterus is not same throughout the life. There are changes occurring in its shape, size throughout the life of a female. So now we will discuss uterus in different phases of the life. Firstly, uterus in childhood. In childhood, uterus is small and as you can see in the diagram, cervix is larger than the body. Endometrium is thin and the typical angulation that is present between the vagina and uterus is absent. Also, no menstrual cycle occurs during childhood. Now uterus in puberty. Uterus size increases and as you can see in the diagram, the body outgrows the cervix and the ratio between the body and the cervix becomes 2:1. The uterus enlarges and it descends to its normal position, that is adult position. The arbor vitae uteri also appears during the puberty, that are the mucosal folds present in the cervical canal. Also, menstrual cycle begins in puberty. During menstruation, uterus is slightly enlarged and vascular changes occur, that is increase in vascular supply to uterus occurs. Now we will discuss the vascular changes in the uterus in detail. Firstly, in menstrual phase. In menstrual phase, there is a constriction of spiral arteries which leads to ischemia, which causes rupture of vessels and shedding above endometrium. While in a proliferative phase, so spiral artery grows upward and the stoma becomes more vascular due to action of estrogen. In the secretory phase, due to progesterone, there is a coiling and dilatation of spiral arteries and there is desvascularization and the venous lacunae develops. In the premenstrual phase, due to fall in the hormonal levels, there is a plasm of spiral arteries, which leads to ischemia and necrosis and the onset of menstruation. Now we will discuss changes in uterus during pregnancy. As we all know, the uterus enlarges significantly during pregnancy and it became ovoid or spherical shape due to hypertrophy of the muscle. Also, it enlarges and moves out of the pelvis and became forward, that is anteverted and anteflex. The vascular supply to the uterus. Maybe it is forward and became more somewhat more active.
During pregnancy, or it becomes retrograde.
So vascular supply to the uterus increases and there is a development of spiral arteries. Endometrium became deciduous due to the action of progesterone during pregnancy. Due to hypertrophy of the muscles and rich vascular supply, the weight of the uterus increases from 50 to 70 grams to 1000 to 1200 grams. Also, towards the late pregnancy, rectal his contractions occurs, that are the regular painless contractions that begins the preparation for labor. Now we will discuss the uterine heights at different phases of pregnancy. As we all know, implantation occurs in uterus, and along with the fetus, the uterus also grows. And in the 5th month, it is midway between the pubis and umbilicus. At the 6th month, it reaches the level of umbilicus. In the 8th month, it reaches near the zipper process, and it descends downward in the 9th month due to fetal head. As you can see in the diagram, in the 5th month it is present between the pubis and umbilicus. In the 6th month it is between the at the level of the umbilicus, and in the 8th month it is near the zipper process, and it goes slightly lower than that is shown in 8th month. Now uterus in menopause. The uterus became fibrotic, and there is an atrophy of the cervical lips of uterus. The external and internal os may become partially or fully obliterated, and also overall size and the functionality of the uterus declines. These are the diagrams showing the uterus at different phases of the life of the female. These two are the diagrams of the uterus during childhood, where you can see that the cervix is larger than the body. This is the diagram showing the uterus during puberty, where the body is larger than the cervix and the ratio is 2:1. This is the uterus during adult, and this is the uterus at menopause. Now, to explain the relations of the uterus, I would like to call Ritix. Thank you.
Good morning, everyone. My name is Ritix Shura, roll number 46. Today I'm going to be presenting peritoneal and visceral relations of the uterus. As my friend Omkar already talked about different parts of the uterus, the fundus, body, isthmus and cervix. The fundus of uterus lies above the opening of the fallopian tubes on either side, where the fallopian tubes enter at the corner of the fundus. Anteriorly, it is related to the anterior abdominal wall via the urinary bladder and the uterovesical pouch, which is in front. In early pregnancy, the uterus enlarges, due to which the fundus moves forward, and it is the first site of palpation during pregnancy. Posteriorly, the coils of small intestine, especially the ileum and the sigmoid colon, is often seen. As you can see over there, the anterior abdominal wall by the urinary bladder, and posterior, the small intestine, the sigmoid colon is seen.
It is directly in contact with the abdominal wall.
No, there's the urinary bladder and there's the vesico-uterine pouch.
Bladder is in contact with the abdominal.
No, there are ligaments muscles separated.
What lies between the vesico-uterine
Sorry?
What is the content of vesico-uterine pouch? You find out and tell me.
Laterally, broad ligaments of the uterus are seen on either side, with uterine arteries, veins, lymphatics, as well as ureters. And ovaries and fallopian tubes lie superior laterally, and ovaries are connected to the body of the uterus via ovarian ligaments. The structures related to the corner of the uterus from anterior to posterior are the round ligaments of the uterus, the fallopian tubes, as well as the ovarian ligaments. Like in this structure, the round ligaments are seen, fallopian tube, and ovarian ligament is seen, which is attached to the uterus. Now I would like to talk about the peritoneal relations. In the peritoneal relations, the uterus is mostly covered by the peritoneum, except in a few areas which are called the non-peritoneal surface of the uterus. Anteriorly, the peritoneum covers the body, does not cover the cervix, and it reflects onto the bladder, forming the vesico-uterine pouch. And posteriorly, it covers the body as well as the supravaginal part of the cervix, and then reflects onto the rectum, forming the recto-uterine pouch. And in females, this is the lowest point of the peritoneum. As you can see. Laterally, peritoneum forms the broad ligaments, which are double-layered folds of peritoneum that extends from the sides of the uterus to the lateral walls of the pelvis. And the non-peritoneal surfaces of the uterus include the anterior surface of the cervix, lateral aspects of cervix and the parts of the uterus where broad ligaments are attached are not completely peritoneal. The last thing I'll discuss is the peritoneal recesses, which we already talked about, the vesico-uterine pouch and the recto-uterine pouch, which is commonly known as the pouch of Douglas. Vesico-uterine pouch is present anteriorly between the urinary bladder and the uterus. Its clinical applications are the C-section access, endometriosis and retroverted uterus conditions. In endometriosis, the endometrial tissue which is present inside the uterus is found outside of the uterus, and it undergoes the same cyclical changes which take place inside the uterus due to which is thickening and bleeding which often occurs, and the blood cannot escape outside the body, so it gets collected in the two peritoneal recesses. In the applications of recto-uterine pouch, there's common fluid collection site in ruptured ectopic pregnancy, and pelvic abscess drainage is done. Now I would like to call, as you can see, vesico-uterine pouch and the recto-uterine pouch. Now I would like to call Pranav, who's going to explain the ligaments of the uterus.
First of all, thank you to Hitix for setting a platform for my topic. So, good morning everyone. Myself Pranav Padge, roll number 59. At the end of my session, everyone will be knowing about the position of the uterus in the pelvis is maintained by and how it is maintained. So, let us start. So, firstly, we will start with the introduction. The uterus is supported in the pelvis by the ligaments and the muscle tone. Ligaments are characterized into true ligaments and the false ligaments. Classification of the uterine ligaments. True ligaments are nothing but the fibromuscular folds which provide the direct mechanical support, and false ligament which are nothing but the peritoneal folds and maintains the anatomical relations of the uterus. Firstly, the true ligament. True ligament is round ligament which extends from the uterine cornu to the labia majora via the inguinal canal. We will see it in the diagram. So, firstly, this is the uterus and this is the urinary bladder, and the ligament extending from the uterus to the, here we can see the internal opening of the inguinal canal, and it extends to the labia majora. This is the round ligament of the uterus. The function of the round ligament is maintenance of the anteversion of the uterus, and second ligament is the uterosacral ligament which extends from the cervix to the sacrum of the bone, as we can understand from its name. Its function is the maintenance of the retroversion of the cervix. Both ligaments perform the same function. So here we can see the uterosacral ligament which extends between the uterus and the sacrum bone. Third true ligament is the transverse cervical ligament, which is also called as cardinal ligament, which extends from the cervix to the lateral pelvic wall. It is the major supporting ligament to the uterus and also contains the uterine vessels. So here from the uterus to the lateral pelvic wall we can see the cardinal ligament. And fourth is the pubocervical ligament which extends from the pubis bone and to the pubis bone to the cervix, as we can understand from its name, and its function is support to the uterus and the bladder because it lies anteriorly. Now we will discuss about the false ligament, which are peritoneal folds. Firstly, false ligament is the broad ligament which is double-layered peritoneal structure which holds the uterus and ovarian tubes and ovaries. So this is the false ligament, broad ligament which holds the ovary and the ovarian tubes. And second false ligament is the vesico-uterine fold, or also called as uterovesical fold, which extends between the bladder and the uterus, which is a peritoneal fold. So here in green color we can see the peritoneum, which which forms the pouch, and this is the uterovesical fold, also called as vesico-uterine fold. And last one is the recto-uterine fold. It lies between the uterus and the rectum and form the pouch named as pouch of Douglas. Thank you everyone. Now I will hand over to the Prerna for further discussion.
Thank you, Pranav. Myself, Prerna Tapaye, roll number 57. Now, I will be concentrating on the topic supports of uterus. Now, you must be wondering that why the supports are important for the uterus. As we know, uterus undergoes extensive changes in its size and shape during reproductive period of life. To prevent from sagging down through vagina, these supports are important, and these supports are basically primary support and secondary supports. Now I will elaborate the primary supports. These are mainly muscular supports and fibromuscular supports. Muscular supports or active supports include pelvic diaphragm, perineal body, and distal urethral sphincter mechanism. Pelvic diaphragm supports the pelvic viscera and resists rise in intra-abdominal pressure. Along with this, it forms sling around the vagina, giving support to the uterus. This is the pelvic diaphragm made of muscles levator ani and coccygeus. Levator ani is in turn made up of pubococcygeus and iliococcygeus. Pubococcygeus is inserted on the perineal body, thus fixing the perineal body. And sometimes during parturition, this pubococcygeus can be torn, leading to sink of uterus into the vestibule, causing uterine prolapse. Next is the perineal body. It is nothing but fibromuscular node formed by attachment of 10 muscles, and these 10 muscles are 2 superficial transversus perinae, 2 deep transversus perinae, to pubococcygeus part of levator ani, to bulbospongiosus muscles, 1 sphincter ani externus, and lastly the unstriated fibers of longitudinal muscle coat of anal canal. This perineal body anchor for pelvic diaphragm and maintain the integrity of pelvic floor. Third, urethral sphincter mechanism. Muscles of urethral sphincter, that is compressor urethrae and sphincter uretrovaginalis, are inserted into vagina, giving indirectly support to the uterus. Now moving towards the fibromuscular supports or mechanical supports. This include uterine axis and these two ligaments. Let's discuss this one by one. First, uterine axis. The anteverted position of uterus prevents itself from sagging down through the vagina, and this position is maintained by forward pull of round ligament to the uterus and backward pull by the uterosacral ligaments. Next, transverse cervical ligaments of Mackenroth, also known as cardinal ligaments, paracervical ligaments, and lateral cervical ligaments. These are the cardinal ligaments connecting upper vaginal wall and lateral aspect of cervix to the lateral pelvic wall. Ureter along with the uterine artery passes through these cardinal ligaments. Next, uterosacral ligaments and pubocervical ligaments. Here in this diagram, we can see this is the cervix, and anterior to this are the pubocervical ligaments connecting cervix to the pubis, and posteriorly are uterosacral ligaments connecting cervix to the sacrum, and these are the cardinal ligaments connecting cervix to the lateral pelvic wall, and these ligaments form sling around the uterus, giving support to the uterus. Lastly, round ligaments of uterus. These are the fibromuscular bands of length 10 to 12 centimeter, and these ligaments pass between the two layers of broad ligaments. Round ligaments begin at the lateral angle of uterus, passes through deep inguinal ring and merges with the tissue of labium majus. During fetal life, round ligament is accompanied by process of peritoneum and it persists even after birth, known as canal of Null. That's all about my part. Now I'd like to call Kalash.
Good morning everyone present here. I am Kalash Mundada, roll number 55. Today I will be explaining the topic of pelvic diaphragm. All of us have learned about the thoracoabdominal diaphragm, which was a muscular separation between the thoracic and the abdominal cavity. This is the pelvic diaphragm, which acts as a muscular separation between the pelvic cavity and the perineum. It acts as the floor of the pelvic cavity and it also provides support to the pelvic viscera. Talking about its resemblance, it resembles a hammock. Hammock means it resembles a gutter with sloping fibers directed medially from either side, which are traversed by 3 openings, which will be discussed ahead. Talking about the components, as already explained, it includes levator ani and ischiococcygis. This levator ani is comprised of pubococcygis and iliococcygis. Now I would like to talk about details of these muscles. Talking about pubococcygis, it can be studied in 3 main parts: anterior fibers, middle fibers and the posterior fibers. So talking about the anterior fibers, they originate from the medial part of the pelvic surface of the body of the pubis. And insertion, it inserts on the perineal body. They also wind around the prostate gland in males and the vagina in females to form levator prostatae and sphincter uretrovaginalis. Here we can see the pubococcygis muscles anterior fibers. Now talking about the middle fibers comprise the puborectalis. It mainly wind around the anorectal opening. And talking about the origin, it originates from the lateral part of the pelvic surface of the body of pubis, and its anterior portion is thinner and shorter in case of females. Here we can see the puborectalis means the middle fibers, and one more point, it is partly continuous with the longitudinal muscle layer of the rectum. Talking about the posterior fibers, they originate from the anterior half of the white line of the obturator fascia. This white line is a tendinous arch, and they will insert on the anococcygeal ligament and the tip of the coccyx. Now talking about iliococcygis, this iliococcygis muscle originates from the tendinous white arch, which was described previously, that is the white line on the obturator fascia, and also from the pelvic surface of the ischial spine. It inserts on coccyx and the anococcygeal ligament, and it is thinner and more aponeurotic. This is the iliococcygis muscle. Talking about ischiococcygis, this ischiococcygis muscle arises from the pelvic surface of the ischial spine and from the sacrospinous ligament, and it will insert on the coccyx and the 5th sacral vertebra. It is partly muscular and partly tendinous, and it will form the posterior part of the pelvic diaphragm. Here we can see the ischiococcygis. This is one more section showing the different muscles, like
Which section? Which section? Coronal? This is coronal.
this is the coccygeus, this is the iliococcygis, and this is the pubococcygis. This coccygeus is nothing but the ischiococcygis only. Now talking about the actions of the levator ani, it forms the posterior part of the pelvic outlet, and it also fixes the perineal body and supports the pelvic viscera, as already described earlier, that it forms one of the supports of the uterus. It maintains the continence of the bladder and rectum, and this function is mainly performed by the muscle puborectalis. This puborectalis muscle, as already described, binds around the anorectal opening and it regulates the process of defecation. Actually, the anorectal angle is around 80 degree, but during the defecation, this angle increases by 20 to 30 degree because of the relaxation of this muscle. So puborectalis ultimately prevents the untimely descent of the feces. Actions of the coccygeus. This muscle has not a very great significance in humans now, but still it has some function that it forms the posterior part of the outlet of the pelvis, and also it pulls forward the coccyx and supports the coccyx. Talking about the vascular supply, it is supplied by the internal pudendal artery, the inferior vesical artery, and the inferior gluteal artery, all of which are the branches of the anterior division of the internal iliac artery, as it can be seen here. Now supply, the levator ani is supplied by the fourth sacral segment of the spinal cord and also by the branches of the inferior rectal artery, while this coccygeus is supplied by the fourth and the fifth sacral segment of spinal cord. Talking about the relation, the superior surface is known as pelvic surface because it faces the pelvic cavity. It is covered by the pelvic fascia and it has relation to the organs which are present in the pelvic cavity, like the bladder and the uterus. Other than that, the inferior surface, perineal surface, which faces the perineum, it is covered by the anal fascia. And we can also here see that this is the ischioanal fossa, and it forms the medial boundary of the ischioanal fossa, this levator ani muscle. Anteriorly, the fibers of these two muscles, they have a separation between them. This separation provides a gap for the passage of urethra and the vagina, as it can be seen in this diagram. Posteriorly, the posterior margin is a free margin and it lies opposite to the anterior margin of the coccygeus, anterior border of the coccygeus.
So in places you are referring to the muscle as ischiococcygis, and places you are calling it as coccygeus. Fine? They are same. Use one term.
Ischiococcygis. Now, at the start of my presentation, I talked about the pelvic opening at the openings of the pelvic diaphragm. Now I will be describing them anterior to posteriorly. In case of females, the order is urethral opening, vaginal opening, and the anorectal opening. And in males, the vaginal opening is absent. It can be seen in this diagram. Talking about the function, it supports the pelvic diaphragm, bladder, means all the structures in the pelvic viscera, and it maintains the urinary and the fecal continence. Other than that, it also facilitates the childbirth because there is a rotation of the child, means the head turns forward, the position changes from the transverse position to the anterior posterior position, and it also responds to the increased intra-abdominal pressure by counteracting the same pressure. So it maintains the stability of the uterus. Talking about the clinical significance, if there is any trauma or injury to the muscles of the pelvic diaphragm, then it can lead to the prolapse of the various pelvic organs. In this diagram, the different organs prolapse can be seen, like the prolapse of vagina, the prolapse of the uterus, which will be explained further, and also the prolapse of the urinary bladder. Incontinence will be seen because obviously the muscles of the pelvic diaphragm are important to regulate the opening of the anorectal junction, and also during the now talking about childbirth trauma, during the process of parturition, there can be certain injuries or trauma to these muscles which can cause the above two conditions. Levator ani syndrome, it is a pain in the levator ani muscle because of its chronic contraction. That is seen in the case of chronic constipation. Now I would like to call upon my friend Samadhan to explain further.
Are these muscle fibers in continuity or there is a gap? They are in continuity.
Good morning everyone, myself Samadhan Okay, roll number 48. Earlier my friend explained about primary support of uterus. Now we will discuss about secondary support of uterus. Firstly, what is secondary support of uterus? Peritoneal and fascial structure that support and maintain position of uterus by anchoring it. It includes broad ligament, uterovesical fold and rectovaginal fold. First we discuss about a broad ligament of uterus. Double layer, what is broad ligament of uterus? A double layer of peritoneum that extends from lateral side of uterus to lateral pelvic wall. It includes three parts: mesometrium, mesoorium and mesosalpinx. We discuss all one by one. First, in this diagram we see all these mesometrium superior to it, mesosalpinx and near mesoorium. First we discuss about mesometrium. It is largest portion and extend from lateral uterine wall to pelvic side wall. It contains uterine vessels, nerves and lymphatics. Mesoorium. Each ori is attached to the posterior surface of broad ligament by a short peritoneal fold known as mesoorium. Mesoorium acts as a hilum of ori where vessels and nerves passes through it. Mesosalpinx. The portion that suspends the uterine tube. It lies superior to the mesometrium. Now see external features of broad ligament. It has two surfaces. When bladder is empty, superior and inferior surface, and when bladder is distended, posterior surface and anterior surface. And two borders. When bladder is empty, it has anterior free border and posterior attached border, and when bladder is distended, upper free border and inferior attached base. Now, content of broad ligament. Broad ligament contain uterine tube, two ligaments, round ligament of uterus and ligament of ovary, and two arteries, uterine artery and ovarian artery. Two plexus of nerve, uterovaginal plexus and ovarian plexus. Three embryological remnants, epooperon and its duct, paraoperon. These remnants, epooperon and paraoperon are the remnant of mesonephric duct, and vesicular appendices is a remnant of paramesonephric duct. Other structures, lymph vessels and lymph nodes and fibroareolar tissue. Now we can see the sagittal section of broad ligament. Here ligament of ovary and ligament of uterus, fallopian tube and uterine artery. And in posterior aspect we see ovarian artery, epooperon and paraoperon and uterine artery. Now we discuss uterovesical fold and rectovaginal fold. First, uterovesical fold. These are peritoneal fold which reflected from front of uterus to the upper surface of bladder at the level of stomach. Rectovaginal fold. These are peritoneal fold reflected from back of posterior fornix of vagina on to front of rectum. Here we see uterovesical fold and rectovaginal fold. Earlier, my friend explained about pouch of Douglas. It also known as rectouterine pouch. The pouch of Douglas lies between posterior surface of uterus and anterior wall of the rectum. In supine, free fluid still gravitate into the pouch of Douglas because it is lowest point of pelvic cavity. The counter of the pelvic organs and the angle of pelvis allow gravity to full fluid there. Applied importance of pouch of Douglas. Collection of pus or blood in the pouch of Douglas may be removed by incision in posterior fornix of vagina without opening of anterior abdominal wall. Now further discussion. I will call my friend Abhijit Kadam.
Uterine and rectovaginal pouch is same. At place you said rectovaginal. One sentence rectovaginal. We are same. Fold. Same and rectouterine rectovaginal. So rectouterine and vaginal.
Thank you, Samanan. Now, my name is Abhijit Karam, roll number 53. Explain about the blood and nerve supply of uterus. The arterial blood supply of uterus, it is mainly supplied by the two uterine arteries and the partly by the ovarian arteries. The uterine artery is a branch of anterior division of internal iliac artery, and it mainly supplies to the uterus body, the two-third part of fallopian tube and the vagina. Uterus as a living ligature. During delivery, there is an expression. The placenta is removed from the body. Due to this, there is an increased blood loss from the body. To prevent the blood loss, the myometrium layer of myometrium consists of two layers, outer and inner layer. Inner layer consists of an oblique muscle fibers, and the uterine artery passes through it. The tortuous course of uterine artery is surrounded by these fibers, which causes the constriction, which contract and prevent the blood loss by the constriction of blood vessels. That's why the myometrium layer of uterus is called as a living ligature or the physiological suture. Talking about the clinical anatomy, the structure which is close proximity to the uterine artery is the ureter, which is, the uterine artery passes from in front of ureter and passes through lateral to the medial side and passes between the layer of broad ligament. During surgery, the two structures lies very proximal to each other. That's why care should be taken to prevent any damage to the structures. The venous drainage of an uterus, it is mainly by the venous plexus, which is formed by the uterine and ovarian veins lateral to the uterus, and it's drained into the internal iliac vein. Talking about the nerve supply of uterus, it is mainly supplied by the sympathetic and parasympathetic nerve supply. The sympathetic nerve supply is mainly by the T12, L1 and L2 segments of spinal cord, which causes the uterine contraction and the vasoconstriction. And the parasympathetic nerve supply is mainly by the S1, S2, S3 and S4 segments of spinal cord, which causes the inhibition of uterine muscle contraction and the vasodilation. Mainly the hormones control the uterus, and the autoregulation of uterus is less. In this image, you can see the ureter passing behind the uterine artery, the venous plexus around the uterus, and the tortuous course of uterine artery. Thank you. Now I will call Swam to further explain about
Where
the
does the uterine vein drain?
internal iliac vein.
And internal iliac veins?
Common
Good morning everyone, myself Soham Kalal, roll number 54. And my topic is lymphatic drainage of uterus. The lymphatic drainage of uterus begins in three interconnected plexuses. So let's first understand what are the plexuses. The lymphatic plexus is a network of interconnecting in which the lymphatic vessel collect lymph from tissues and drain into the larger lymphatic vessel, and further the larger lymphatic vessel drain lymph into the lymph nodes. The three interconnected plexuses are endometrial plexus, myometrial plexus, and subperitoneal plexus. The endometrial plexus lies in the lining of the uterus. The myometrial plexus lies in the muscle layer, and the subperitoneal plexus is beneath the peritoneal cavity. All drain laterally towards lateral pelvic walls. These plexuses give rise to regional lymphatic drainage zones. and based on which part of the uterus is being drained, the uterus is divided into three parts: the fundus and the upper part of the body of the uterus, the lower part of the body of the uterus, and the cervix. So first, the fundus and the upper part of the body of the uterus. Here the primary drainage is into the para-aortic nodes, which lies near the L1 lumbar region. These nodes follow the ovarian vessels via the suspensory ligaments of ovary. The secondary drainage is into the superficial inguinal nodes. Here the lymph follows around ligament through inguinal canal, and it is the important path for fundal cancer to reach the palpable inguinal nodes. The second is lower body of the uterus. Here the main drainage is into the external iliac lymph nodes, and they lie along the uterine vessels with the broad ligament. Third part is cervix, and here the primary drainage is into the internal iliac lymph nodes, and secondary drainage is into sacral lymph nodes, common iliac lymph nodes, and obturator lymph nodes.
What do you understand the primary drainage?
The primary drainage is when the lymph vessels collect lymph from tissues, and the lymph vessels which further drain into the secondary lymph vessels with the second.
I am not understood. You will explain to me.
And the lymph nodes of cervix are so dense, so they follow the two key ligaments, cardinal ligament and uterosacral ligament. Dense network is crucial in cervical cancer. So here, as I said, on the basis of which part of uterus is being drained, it is divided into three regions. This is the fundus and upper part of the body of uterus. This is the lower part of the body of uterus, and this is the cervix. The lymphatic, this region drains lymph into pre and para-aortic lymph nodes and superficial inguinal lymph nodes. This region, which
So
is
territory is different. The dotted lines are territories. So the territories are different. Huh? So how can it be primary and secondary? The area of drainage is different in the picture. But आगे बढ़ो.
the lower part of the body of the uterus drains into external iliac lymph nodes, and cervix drains its lymph into sacral lymph node, external iliac lymph node, internal iliac lymph node, and obturator lymph node. Now, I would like to pass on to continue the presentation.
Good morning everyone, this is Sanika Odbe, roll number 47. I will be discussing the types of uterine prolapse and their effects. So what is prolapse? Prolapse is a medical condition in which an organ or tissue slips out of its normal position due to the weakened musculature support or connective tissue.
Normal aperture, normal anatomical aperture or abnormal aperture?
Abnormal aperture.
Abnormal aperture. Vaginal aperture is abnormal.
So, normal aperture. But it is not supposed to herniate. We are mainly concerned with the pelvic organ prolapse. It refers to the descent of pelvic organs like uterus, cervix, bladder, rectum, etc. into the vaginal canal due to the weakened musculature support. The genital prolapse occurs due to the weakness of the structure supporting the organs in position. These factors may be anatomical or clinical. The factors are discussed here. The anatomical factors are gravitational stress due to the human bipedal posture, the anterior inclination of the pelvis, directing the force more anteriorly, stress of parturition, and pelvic floor weakness. The clinical factors are again subdivided into two factors, that is predisposing and aggravating factors. The predisposing factors can be acquired and congenital. Congenital is due to the inborn weakness of the musculature support, and the acquired is due to the trauma of vaginal delivery, causing the injury to the ligaments, endopelvic fascia, muscles, and nerves, especially the pudendal nerve. And aggravating factors can be the postmenopausal atrophy, increased intra-abdominal pressure, as in case of constipation, obesity, and weightlifting. The types of pelvic organ prolapse are mainly subdivided into vaginal and uterine prolapse. The vaginal prolapse differs from uterine prolapse in that the vaginal prolapse is independent of the uterine descent, unlike the uterine prolapse. The vaginal prolapse can be again subdivided into different types based on which vaginal wall is involved in the prolapse. If there is involvement of the anterior vaginal wall, it can be divided into the three types: cystocele, urethrocoele, and cystourethrocoele. The cystocele refers to the herniation of urinary bladder through the upper two-thirds of the anterior vaginal wall. It is most commonly seen in the second degree prolapse. The symptoms are urinary symptoms, which is difficulty in the passing of the urine, painful micturition.
Stress incontinence.
Yeah, stress incontinence is due to the urethrocoele, associated urethrocoele. The urethrocoele refers to the herniation of urethra through the lower one-third of the anterior vaginal wall. And the cystourethrocoele is the combination of the cystocele and urethrocoele. When there is involvement of the posterior vaginal wall, there is three types of vaginal prolapse can be seen: relapsed perineum, rectocele, and vault prolapse. The relapsed perineum is when there is a torn perineal body causing the gaping of the introitus with the bulging of the lower part of the posterior vaginal wall. The rectocele is when there is herniation of the rectum through the posterior wall of the vagina. It is commonly seen in the second degree or third degree prolapse.
So I am not understood what is prolapsing there. The rectum is prolapsing in vagina, or vagina is
Rectum.
along with rectum, vagina is prolapsing outside.
Specifically in the rectocele, there is the herniation of the rectum in the posterior wall of the vagina.
Rectum is prolapsing in vagina.
Yeah.
It is rectal prolapse.
But it is under the pelvic organ prolapse. Then vault prolapse. There are two types of vault prolapse: primary and secondary. The primary one includes the enterocele, where there is the herniation of the bowels, intestines into the the herniation of pouch of Douglas containing the omentum and the small bowels into the posterior vaginal wall. And the secondary prolapse is due to when there is vaginal hysterectomy and abdominal hysterectomy. The uterine prolapse is mainly classified into the uterovaginal prolapse and the congenital prolapse. Congenital prolapse is usually not associated with the cystocele. It is caused due to the inborn weakness of the musculature supporting the uterus in position, and it is often seen in the nulliparous women, so also called as nulliparous prolapse. The uterovaginal prolapse is when it is the prolapse of uterus, cervix, vagina or the upper vagina. It is the most common type of genital prolapse. Cystocele occurs first, followed by the traction effect on cervix, leading to the retroversion of the uterus. Then the uterine prolapse can be graded based on the severity of the prolapse. First degree prolapse, where there is the descent of the cervix into the vagina, but it does not reach the introitus, and it is usually asymptomatic, but mild pressure can be felt at the pelvis. The second degree prolapse is when there is descent of the cervix up to the introitus, sensation of something coming down and a dragging pain in the lower abdomen and the back can be felt. The third degree prolapse is there is the cervix protrudes outside the vaginal introitus, and a visible bulge outside the vagina, and difficulty in walking or sitting can be seen, and there is also urinary retention or incontinence associated with this. The procedentia is also known as complete prolapse or fourth degree prolapse. It involves the prolapse of uterus with eversion of the entire vagina, and complex prolapse in when there is prolapse is associated with another specific type of defect, like when there is a prolapse occurring along with the fecal or urinary incontinence, or when there is recurrent prolapse. These is quantitative grading of pelvic organ prolapse. The symptoms in the prolapse can be feeling of something coming down per vagina, especially when the woman is moving.
What is the clinical term for this something coming down for vagina? SCOPV ऐसा लिखते हैं, something coming out for vagina. ये down क्या है?
Out.
Down क्या है?
But it was in that book yes.
Which book?
DC Datta's gynecology.
Down लिखा है?
हाँ. The another symptoms are backache or dragging, pain in the pelvis, dyspareunia, bowel symptoms, urinary symptoms, and excessive white or blood-stained discharge per vagina. Thank you. The next, Janvi will continue.
तुम्हारा roll number 47.
Good morning everyone. Myself Janvi Yadav, roll number 51, and I'll be talking about the development and anomalies of the uterus. So let's begin with the formation of the primitive streak in the 3rd week, and then it undergoes proliferation to form the intraembryonic mesoderm. This intraembryonic mesoderm later divides into 3, which is the paraaxial mesoderm, the intermediate mesoderm, and the lateral plate mesoderm. As we can see here, the paraaxial mesoderm later gets segmented to form the somites. The lateral plate mesoderm forms the intraembryonic coelom or the cavity, and this intermediate mesoderm gives rise to the urogenital system. Initially, it lies between the two of them, that is the paraaxial mesoderm and the lateral plate mesoderm. But after the folding of the head, it goes to form a urogenital ridge, and the surface covering this ridge is called as the coelomic epithelium. This coelomic epithelium undergoes invagination to form the paramesonephric ducts, which is responsible for the formation of the uterus. So the development of uterus can be divided into 5 topics, that is formation, migration, fusion, canalization, and septal resorption. Let's understand it better with the help of a diagram. So these are the paramesonephric ducts, which are formed in the 6th peak of the intrauterine light from the coelomic epithelium, which then moves caudally and medially to form the uterovaginal canal. This canal is initially solid and undergoes canalization to become a hollow structure. And finally, there is septal resorption between the 2 ducts to form a single lumen. As we can see it better in this diagram, also the uterovaginal canal opens into the urogenital sinus, and this urogenital sinus also forms a sinovaginal bulge responsible for the formation of the lower 1/5 of the vagina. Let's see the structures formed. So the fallopian tubes are formed from the unfused cranial ends of the paramesonephric duct, whereas the caudal fused parts gives rise to the uterus, cervix, and the upper 4/5 of the vagina, and the lower 1/5 of the vagina is formed from the urogenital sinus. Talking about the congenital anomalies, we can classify it into a few types: failure of fusion, failure of septal resorption, agenesis, and mild anomaly. Let's discuss each one in detail. The diadelphous uterus. It takes place in the absence of fusion and gives rise to 2 separate uterus, 2 separate cervix, and 2 separate vagina. The fertility may be normal, but there are high rates of miscarriage. This is known as the diadelphous uterus. The biconjugate uterus is wherein there is partial fusion, and therefore we have a single cervix and vagina, but 2 small horns of uterus. The septate uterus is wherein there is normal fusion, but there is a problem in the midline septum which fails to regress. It is also important to note that this may appear similar to that of the biconjugate uterus, as there is a single cervix and a vagina but 2 uterine horns. The uniconjugate uterus is an example of hypoplasia, wherein one paramesonephric duct fails to form, and therefore there is a rudimentary horn and a small single uterus. Arcuate uterus is wherein there is normal formation, there is normal fusion, normal resorption, but there is a small indentation in this fundus. So let's check our knowledge. Can anyone tell which is the first one? It's the bicornuate uterus, because we can see there are the two uterine horns and there's a single cervix and a vagina. Also there is there's partial fusion taking place. Which is the next one? Right. It is a septate uterus, because again we have proper fusion but there is a problem in the septal resorption. The next one? That's right. As we can see a small indentation here in the fundus. Sorry. Okay, this is the diadelphous uterus, which is very obvious because there is formation of two uterus, two cervix and two vagina. Thank you. I would like to call Samadhan. Sandesh, sir. Yes, ma'am.
So, are these anomalies causing any problem in pregnancy?
Yes, ma'am, it can cause infertility because there is high risk of miscarriage.
One question, please. You said paramesonephric duct, na? What is the another name of paramesonephric duct?
Mullerian ducts.
Why
Mesonephric
is
and
this called
paramesonephric.
paramesonephrine?
Because there are mesonephric.
Lying lateral to the
That's what.
lying lateral to where?
Mesonephric duct
On
के
the
lateral
sides
में.
of the hair.
Good morning everyone, myself Sandesh Kalse, roll number 56. I am going to talk about the investigations of the uterine prolapse. Whenever we are investigating a case regarding the uterine prolapse, we have to investigate in a certain sequence. First, we will do the physical pelvic examination, then ultrasound sonography, and then cystoscopy, and at the last CT scan and MRI will be there. In physical examination, we will do the vaginal examination and bimanual examination. In vaginal examination is done by the inspection and palpation. In inspection, vagina is first inspected at the introitus by separating the labia minora with the left hand. And after that, the speculum examination is done to inspect the cervix and the vagina wall. In palpation, which can be done by per vagina digital examination, whenever an examiner is palpating, he will feel anteriorly the urethra, bladder and pubic symphysis. Posteriorly, he will feel rectum and pouch of Douglas. Laterally, the ovary, fallopian tube, lateral pelvic wall, and thickened ligaments and ureter, and superiorly there will be cervix. Now let's see the bimanual examination, which is also known as abdominal vaginal examination. It helps in the assessment of the size and position of the uterus, enlargement of the ovaries and fallopian tubes, and all the pelvic masses. Now let's see the physical examination in lithotomy position. This position allows for direct visualization of vaginal walls and any visible prolapse. It helps in the assessment of degree and integrity of pelvic muscles. If the prolapse is not seen, then patient is asked to stand and strain. And if the prolapse is there, the prolapse becomes evident by gravity and pressure. Per rectal examination, which is also known as digital rectal exam, which helps to assess uterine prolapse, but it is primarily used to evaluate the rectal prolapse. Now let's see the ultrasound examination, which helps in the assessment of pelvic muscles and the degree of prolapse, and also helps to assess the endometrium and myometrium. It helps to detect the cystocele and rectocele. In cystoscopy, as you can see, the cystoscope helps to assess bladder and urethral function. It is also used in the diagnosis and management of the urethral prolapse. And at the last, the CT scan and MRI. It helps the assessment of exact degree of prolapse in complicated cases like cystocele and rectocele. This is how we have explained the uterus and uterus, its anatomy, and the case regarding uterine prolapse. Now the summary of all the topics that we have discussed will be taken by Shruti.
Thank you, Sandesh. Good morning, everyone. Myself, Shruti Kinarkar, roll number 60, and I am here to summarize the topic. So, as we have seen, the uterus has fundus, body, cervix, and cornu, in which cervix of the uterus has
two parts which are mainly supravaginal and vaginal, and it has two opening. Those are external and internal opening. Nextly, axis of uterus. The angle formed using axis of uterus are anteversion, which is of 90 degrees, and second is anteflexion, which is of 125 degree. Then let's see about the changes occurring in the uterus during age. In the childhood, it is non-functional. During puberty, the menstrual cycle begins. In the pregnancy, it enlarges, and during the menopause, it shrinks. Nextly, the ligaments are of two types, that are true and false. The true ligaments give the mechanical support, and the false ligament have the peritoneal folds. Looking toward the support of the uterus, there are two types of support, that is primary and secondary support, which help the uterus from sagging. Looking toward the primary support, which gives the muscular support and mechanical support. The muscular support includes pelvic diaphragm, perineal body, and the distal urethral sphincter mechanism. Now mechanical support, which includes uterine axis, transverse cervical ligaments, uterosacral ligaments, pubocervical ligaments, and the round ligaments. Nextly, the secondary support of the uterus, which includes broad ligament, uterovesical fold, and the rectovaginal fold. Now the blood supply of the uterus, which is mainly supplied by the two uterine arteries and the two ovarian arteries. Now the nerve supply of the uterus, which is supplied by the sympathetic, that is from the T12 to L2 segments, and the parasympathetic is supplied by the S2 to S4 segments. Venous drainage corresponds to the arteries. Lymphatic drainage is from the endometrial plexus, myometrial plexus, and subperitoneal plexus. Developmental phases of uterus includes the paramesonephric ducts. Now looking toward the investigation for the uterine pathology, which includes physical pelvic examination, ultrasound sonography, cystoscopy, CT scan, and the MRI. Now let's take a look at the case. As we know, the case is all about the 38-year-old multiparous woman presents with the feeling of pelvic heaviness and something coming down in the vagina, especially at the end of the day or after lifting her toddler. About it, the obstructive history is of 2 full-term vaginal deliveries. The diagnosis of the case is second-degree uterine prolapse. Now looking toward the management of the prolapse, which is done by the prevention, hormonal replacement, pessaries, and the surgeries. In prevention, we can see that there is a limit. First, we can do is limiting the injury to the pelvic support during the childbirth. For this, avoid the prolonged labor, difficult instrumental delivery, the small family size, and the postnatal pelvic floor exercises. We can also do avoiding factors which increase the intra-abdominal pressure, and then the prevention of the postmenopausal atrophy of the pelvic support can also help in preventing this. Now looking toward the conservative management, which includes the pelvic floor exercise rehabilitation, which includes pelvic floor exercises. They are also known as Kegel exercises. Nextly, the hormonal replacement and pessaries, which is unfit for surgery. Now looking toward the surgical treatment, which includes the reconstructive surgery, which is the most commonly preferred, used to correct the multiple defects. Nextly, the vaginal hysterectomy with the pelvic floor repair, also known as wide myo repair. Second is the Manchester or fourth Gills operation, and third is Shirodskar extended Manchester or vaginal sling operation. The route of this surgery is mostly vaginal, and it is used in the case of systole, enterocystole, and the rectocele. It is used in the case of cystocele, enterocele, and the rectocele. Now here we will be conducting a small quiz where I will be reading the question and option, and you have to guess the correct answer. So the first question is, in the prepubertal uterus, the ratio of the cervix to body is? Okay, let's see the answer. Okay, everyone is right. It is the second option, 2:1. Next question, which part of the uterus is large during the childhood? Cervix. Okay, cervix. Yeah, you are also absolutely right. Nextly, what is the common positional change of uterus after the menopause? Are you sure? Yeah, it's B. After looking at your response, we can clearly see our team has done a great job.
आंसर पहले से बता दिया है।
नहीं ना। Which muscular layer of the uterus is called as living ligature? Okay. Yeah, it's absolutely right. Myometrium. Nextly, the failure of the fusion of the caudal parts of the paramesonephric ducts results in which of the following uterine anomalies? Yes. Anomalies. Anomalies. Okay, sorry. Guys, which one is the answer? Okay. Yeah, you are absolutely right. Nextly, in the first degree uterine prolapse, the cervix A lies outside the introitus, B lies at the introitus, C lies within the vagina but below the ischial spine, and fourth lies within the vagina but above the ischial spines. Okay, D again from this side. D, C. Okay, let's see. Guys, it's D. This side is clearly winning the game. So nextly, which of the following is not alternative name for the cardinal ligament? A. Lateral cervical ligament, uterosacral ligament, C. Ligament of Macon-Rod, and the D. Paracervical ligament. Guys, this from this side. Okay, B from B. Okay. Okay, you are right. This is B. The cervix drain lymph into the following except first external iliac, B internal iliac, C superficial inguinal, and D sacral. Yes? C. Okay, let's see. Yeah, it is absolutely right. It's C. Ninth, which of the following muscle is not a part of levator ani? C. On this side. What about this side? Right? C? Okay. Yeah, it's right. It's C. Now last question. What is the most appropriate initial clinical method to diagnose the uterine prolapse? Transvaginal ultrasound, second physical pelvic examination, C MRI pelvis, and D hysteroscopy. Yes? Option B from this side. B from? No, this side is clearly losing the game. So B option? Yes, this is right. Thank you one and all for your support. I would like to thank Ms. Dr. Minalini ma'am for guiding us throughout our journey. Ma'am guided us from literally 1 week. She has been tolerating us. Thank you ma'am for tolerating us.
So before I call upon the other staff members, I request Mrinalini madam to speak about her experience.
Congratulations to the entire team. It was a fantastic one. And I would like to tell something that more and more content should be from the textbook and not from the online. Please follow this rule for your entire life. See, physical material, what is given in the books, that is authentic material than the online. And listen, until you read that, you will not be able to differentiate which is correct and which is non-correct. So stick to the books. And also, from many of your experience standing over here, you must have realized how sleeping faces feel like. Okay, seeing to the sleeping faces. So that is not a welcome sight. So when we reverse the roles, this side and this side, the experience is different. And also, it was a great one, and thank you for listening. Today the chaos was slightly less. So we can consider this as a success of the seminar. Okay, thank you very much. It was nice.
Thank you. So, any of the students want to speak? How was the experience in preparation?
I would like to thank everyone and especially Imrani ma'am for guiding us so much. Literally, she helped us in everything and finding content and editing PPT and everything. So I would like to thank you. Thank you, ma'am.
Any other staff member wants to comment on the
It
same?
was excellent. Very good. At first MBBS level, it was very good.
Again, a very good seminar, another hit seminar. I was sitting and I was seeing it is not a first MBBS students present in the seminar. It was like a national or international seminar conducted by the OBGY department. And that is what it was less chaos and everybody was listening very carefully. And I was listening it carefully. I got one doubt as usual. I have a doubt regarding the angle of anti-flexion. What is the angle of anti-flexion? Huh? Because two different measurements are I observed. You also observed, no? Yeah. So whenever you are having the slides, please refer to each other. So that it should be uniform, whatever, and it should be from the textbook as Madam said. Okay, that is one thing. And second thing, important surgically is a McInrod's ligament, transverse subarachnoid ligament, McInrod's ligament. That is also a very important thing. And third important thing is myometrium. Okay, uterus is having the endometrium, myometrium, and the perimetrium. Particularly myometrium of the uterus, it is a much more vascular. So much blood vessels are there. That's why sometimes it is also called as a stratum vasculaire, another term for the myometrium. Okay, and that plays very important role after parturition. The arrangement of the smooth muscles of the myometrium helps for the stopping blood after parturition. Okay, that is all. That is all regarding from my side. Thank you. Very well organized and conducted, executed by the students. Congratulations. Thank you.
So, very nicely presented seminar, nicely guided by Mrunalini madam. On my side, yeah, everybody was good. It was very informative for all of us. On Saturday, what is there? Saturday, anybody knows? क्या डेट है सैटरडे का? क्या होता है 21 जून? वर्ल्ड योगा डे. Yoga day. So there are multiple things. The simple of pranayam what we do. हमारे बच्चे इतने जिम में मिलते हैं मुझे शाम को 4 बजे. But let me tell you that there are some things which even cannot be done in the gymnasium. Like for example, I don't know how many of you have learned yoga because this is connected to the topic. So there is like this Bhastrika pranayam where you breathe in. 21st maybe I'll take a session for you on this. Because what happens is, unless you are engaging in any activity where you are deeply breathing, the lung unused portion undergoes atelectasis because body thinks that this portion is not used. If you don't use the muscles wasting is happening. So kind of wasting of the lung tissue happens. So therefore this deep breathing. In the second, they do this Kapal Bhati. You must have seen morning your father, mother watching.
Ramdev Babu.
What happens is all those germs, dust particles which are entering. Now there is no exercise in the gym by which you can take out the carbon which has gone inside. You can take out the dust which has gone inside. So the way this flapping of the abdominal wall, you throw out. वो fourth है जो आप कर रहे हो. Now the third one also आपने आते जाते देखा रहेगा that Ramdev Baba is pulling his abdomen inside, almost like anterior abdominal wall, posterior abdominal
Scaphoid.
Scaphoid. उसमें there are 3 bandhas. One is called as Mool Bandha, where the perineal muscles they contract. They contract the perineal muscles. They tell you, then pull the abdomen inside and pull the neck like this. So that process of contracting the perineal muscles reduces the chances of prolapse. Now here, of course, this exercise is what you mentioned, it is also part of it. But if one is practicing our own techniques, or traditional Indian techniques, pulling the abdomen inside, what he does prevents inguinal and femoral herniation. So 2 types, this one yoga called as the Bahya Pranayam, where we do the 3 bandhas, उसमें से एक prevents prolapse and one prevents herniation. Okay, so we should not wait कि after 30, 40 age, we go to the doctor saying that क्या था वो symptom, foreign body sensation or some heaviness. Why if we are practicing it from now on, every one of us, many of the doctors also they get hernia because we are not doing exercise of the anterior abdominal wall. So abdominal and anterior abdominal wall becomes lax. Similarly, we are not doing any exercise of the perineal muscles. So if we are contracting it, doing yoga in the morning, at least some time, so then there is no question of this prolapse and such things happening. The whole principle of Ayurvedic lifestyle, or what is our Indian traditional lifestyle, is prevention of diseases. What we speak here is what to do after this female comes to us at the age of 50. But if same female would have practiced yoga, she would have not come to you only with all these problems. Telling you this right now is try to practice all such things. I'll put the link also. I have been taking this session on each yoga day for the students. So I'll put the link. Myself in my second MBBS, I had deviated nasal septum and I had gone to the ENT surgeon and she said do pranayam. First time I heard the word. And I didn't do that for 7-8 years. And at the end of, after 10 years after that, बॉम्बे में एक जोर से रेंज हुआ था 2005 उसमें मैं घर में अकेला था और मेरे पास खाली एक ही सीढ़ी था रामदेव बाबा का सीढ़ी एंड मेरे साथ श्याम किशोर सर जो घर नहीं जा पा रहे तो सर वाज देयर सर वाज टेकिंग रेस्ट एंड आई वाज जस्ट वाचिंग दैट फ्रॉम दैट पॉइंट आई हैव बीन रेगुलरली प्रैक्टिसिंग सो आई एम शेयरिंग विद यू थैंक यू सो मच